Thank you, everybody, for coming. And this is our, what is this, our third one, fourth one, something like that. It's my second. And I'm going to share my screen here. We'll get started. This is what I want. And we're going to go here. Everybody see that?
Yes.
Good.
Yes.
Okay.
Yes.
All righty. So before we get started, I just want to kind of tell you about some previews of coming attractions. The first is going to be on Wednesday, October 12th. Jane Olson, who is the former chair and board of the Board of Trustees of Human Rights Watch International, an incredible humanitarian and philanthropist, another friend of the other Jane. And she's going to be our speaker and is going to discuss her new book available on Amazon called World Citizen. Jane gave a very nice review about the book that's at the front of the book. And it really is a remarkable sort of journey that she portrays with her life in philanthropy and human rights. Whoop, Wendy.
Oh.
So I'm really delighted and honored to have her be one of our speakers. And I think it's going to be a fantastic evening with Jane Olson. In November, we are going to have Dr. Colin Carlson, who's at Georgetown University. He's the assistant research professor for the Center for Global Health Science and Security, and he's going to discuss viral zoonotic spillover events. Recently published paper in Nature, one of the most prestigious scientific journals, discussing climate change and cross-species viral transmission risk, and he will be on Wednesday, November 12th. And I'm really looking forward to what he has to say. He was interviewed recently on, I think it was on NPR and the New York Times, but a specialist in viral pathogens. And it's a very interesting paper that was published in Nature. So he's going to be discussing that. Upcoming other speakers, you might know both of these people. The one on the left is my new friend, Larry Mantle, and he has agreed to do a date in 2023 for us, January or March, possibly. We have to sort of nail that down. And then, of course, our dear friend and honorary board member, Jane Goodall, is also going to be doing one of our speaker series, and we'll announce that date when it's available. So really excited about some upcoming people. And I think this is really turning into a very interesting experience for our members and donors and participants and anybody else who'd like to register. So turn this off. I don't think I need that. Okay, so let's talk about the viruses among us, of which there are two principal ones as of today. And so I'm just going to give you a very brief update on COVID and then talk a little bit about Mpox, MPX, monkeypox, whatever the name is going to be. And we'll talk about that in a couple of minutes. So we are just kind of coming out of the SARS-CoV-2 Omicron BA.5 surge. And this was a pretty impressive surge in terms of the numbers of people who became infected, especially the numbers of people who were fully vaccinated and boosted who became infected. And it speaks to this particular virus in its ability to evade some of the immune responses that we're counting on to try to control this pandemic. You can see here, California is pretty representative. That as the weeks have gone by, we've had a pretty continuous decline. There's still plenty of disease out there, kind of dribs and drabs. We're down or about 10 or 11 patients in the hospital. So don't get too cocky about taking your masks off right now because it's still there, but it we're seem to be over the peak. We hope that this thing lays down for a little bit. This is one of many surges that we've had, and each time we have a surge, although it does cause a lot of disruption in healthcare, and it unfortunately causes a lot of disease in people, some of which can be very serious in the unvaccinated. Each of those events is another layer of immunity that's laid down really around the world. So, if as long as the virus conserves some of its sort of known properties, that should confer a bit of herd immunity as we move forward. That, of course, is all dependent on the hopefully not emergence of a new variant, but we'll talk about that in a second. You can see in LA County, we're experiencing the same thing. There's a decline in hospitalizations, decline in the number of cases. Now, this statistic, the 7-day average and the number of positive cases, is now a little bit skewed because so many people are doing testing at home. So the county is not able to really keep track of the number of cases too well, but it does overall appear to be declining. And thankfully, we also are seeing a decline in deaths. I wanted to show this because what I wanted to talk about a little bit is that the evolution of SARS-CoV-2 during this pandemic is not linear. In other words, alpha didn't give rise to beta, giving rise to delta. These are all different families. And so you can see here that this is the Omicron family. And it first emerged as BA1 and BA2. And that kind of put a few folks out of business for a while. It was kind of fairly brisk, a little mini surge, but then that was rapidly replaced by BA5, which is sort of the big daddy of this crowd. So right now we're really seeing mostly Omicron circulating around the world. There are dribs and drabs of different viruses that crop up here and there, but this has become the dominant one. The good news about the Omicron family is that although it is much, much more infectious, it doesn't seem to be as serious as Delta in terms of causing invasive lower respiratory tract disease. Now, that might be a function of the fact that so many people in the world now have either had COVID or have been fully vaccinated, and so that the disease can't take hold in the lower respiratory tract. But it does appear that the virus has now traded has traded virulence for infectiousness. That's sort of the goal of the virus, is to infect as many hosts as possible, and it can of course infect individuals who are fully vaccinated, and that's been a problem with this particular surge. So it certainly is the most dominant and continues to be the most dominant variant in the United States. It is ultra contagious. It can attach itself to the ACE2 receptors, which are the primary binding site for COVID. It's called increased fusogenicity. And it also has increased viral replication and higher viral loads. And so there's a lot of virus in people's noses, which increases the infectiousness of this pathogen. In addition, it is able to evade some immunity, especially if you're neutralizing antibodies, which are kind of the first forces in your immune system are kind of low, which many people are if they haven't gotten their booster or if they're farther away from their booster. But thankfully, this particular variant does not seem to have increased death and morbidity, but it certainly has taken out a lot of people and is much more infectious. And this is sort of where the business is with SARS-CoV-2, the virus that causes COVID. It's all on the spike protein, and it's one particular area on the spike protein where the mutations occur frequently so that it confers resistance to whatever immunity we have sort of floating around out there in the herd. Again, it doesn't overcome it completely, so being fully vaccinated and boosted is a very, very important part of protecting yourself. But the virus is trying to create mutations that will increase its infectiousness and therefore increase its spread. The R0 value is the infectiousness of the virus. It's a scientific measurement of that. And basically what it reflects is how many people would be infected if they had exposure to one person who was already infected. So the 1918 H1N1 influenza virus is about 2. That's about normal for all of influenza viruses. The first SARS virus, the Wuhan virus, was 3.3. That means 3.3 people would be infected if they were around somebody who had the Wuhan SARS-CoV-2. Ebola is not a super efficient virus because it's more of a contact, and the hosts are so sick that they don't usually have time to wander around and infect everybody else. So it actually has a fairly low R0 value. It's also not particularly a respiratory virus. But as you get up into the respiratory viruses like mumps and measles, it's pretty high, 12 and 18. And in fact, up until 2 months ago, measles was the most infectious respiratory pathogen that we knew of until SARS-CoV-2 Omicron BA5 came along, and its R0 is 18.6. So it is a very, very, very infectious virus, and it can spread very quickly with minimal amounts of viral load. Thankfully, we do have some more developments now. We have 2 FDA-approved medications, EUA-approved medications. The first is molnupiravir, which hasn't been as good a performer as Paxlovid. It does reduce serious illness by about 30%, It does disrupt viral replication, but it doesn't do so as well as Paxlovid does. And there's some concern about its teratogenicity, its ability to cause birth defects. So it's not a medication we can use in the setting of with pregnant women. Paxlovid has sort of gotten the most attention. It is a protease inhibitor medication based on the protease inhibitors that we developed during the HIV pandemic, a very important platform now for antivirals. And it's boosted with the second protease inhibitor, ritonavir, which is a drug that we use in HIV. It does seem to significantly reduce serious risk, much better than molnupiravir. The downside of Paxlovid is that it can cause drug-drug interactions because protease inhibitors are metabolized in the liver. If a person is on other medications that are metabolized in the liver, especially such as anticoagulants or seizure medications or cardiac medications, the drug is kind of contraindicated because it can cause problems. So that's where you may want to use molnupiravir. But by and large, most people, if they decide they want to take an antiviral, will take Paxlovid. The way the drug is taken, of course, is it's 3 pills twice a day. It's in a little preloaded package. You have to start it within the first 3 to 5 days of infection. Most people do report a significant change, but some people can not have much of a response. It's not designed to cure you, and it doesn't probably infect your infectiousness, but it does decrease the risk of serious illness and may shorten your course of symptoms. Many individuals, however, who've taken Paxlovid have now experienced what's called Paxlovid rebound. President Biden and Jill Biden both experienced this. And at first, we were very concerned that this might reflect that the virus is becoming resistant to Paxlovid. Thankfully, that does not appear to be the case, according to this paper that was recently published in CID, which looked at the fact that it retained its effectiveness. It just, the absorption was a bit of a problem. Protease inhibitors have to be taken in kind of a fatty food environment that you have to eat something for it to be absorbed properly. And so it's possible when people are feeling kind of low when they have COVID, their appetite's kind of suppressed and they may not eat as well. And so the drug may not be absorbed at the high enough concentrations to cause full viral suppression. So Paxlovid is proving to be a very helpful tool. It's very safe, except for the drug-drug interactions with some other medications. And it is pretty effective, but it is not a game changer. And we certainly need to have more antivirals down the road. I want to talk for a second about reinfection with SARS-CoV-2. You sort of hear this kind of, well, I'm just going to go out and get it over with, or I got it again, because I was sort of let my guard down. There's a lot of concern about getting reinfected with a virus, even the same virus, even though it might be a little bit different if it's a different family of viruses. This was a retrospective study that was a VA cohort study that was done. It was a large study. It had some sort of issues with the accuracy of it because it was mostly a cohort study, but it looked at individuals that had one infection compared to those individuals who had 2 or more infections. And then they compared that with a non-infected control group that was matched for all the other characteristics of these 2 populations. And what it showed is that reinfection with with SARS-CoV-2 increased the risk of all-cause mortality. This is in individuals, especially individuals who are unvaccinated, but it did occur also in vaccinated individuals. It increased the risk of hospitalization. It may increase the risk of long COVID, and it certainly seemed to have some effect on increasing the risk of adverse health outcomes, such as cardiovascular disease, hematologic disease, pulmonary, even things like diabetes and long-term gastrointestinal problems. So the bottom line is even if you've had COVID, even if you're well vaccinated, you don't want to get it again if you can try to avoid it, because these are concerns, especially not just in the immediate aftermath of being reinfected, but also long-term places down the road. So our best tools so far really continue to be the vaccines. And of course, today, the FDA approved the modified Omicron-specific Moderna and Pfizer mRNA vaccines. And I'll talk a little bit about that in a second. The Novavax protein subunit vaccine, that's a much more traditional vaccine platform. Looks very good. It's also a 2-part vaccine. It's a primer and a second vaccine. They're trying to get approval for booster indications as well, but they have approval now for primary series. And we thought maybe it might be a good alternative for people that were anxious about the mRNA technology, but I'm not sure that it's really increased uptake in vaccination. We know that boosters are very, very important. That the first priming series, of course, is significant, but that boosting is very important. Those that were fully boosted through this last round with Omicron BA.5 probably did better than those that were not boosted. So boosting is a very important part of the vaccination program in fighting COVID-19. We absolutely need a pan-coronavirus vaccine that is independent of the variants that emerge. And perhaps that's a vaccine directed not so much at the spike protein, which is the most mutagenic part of the virus. That's the part that can change the most, but maybe towards a more highly conserved part of the virus, perhaps the sort of guts of the virus, if you will, that all of the viruses have in common. And then there's a lot of work being done right now on nasal vaccines because they may help prevent the infection to begin with. Vaccines are really designed to prevent serious disease and death. That's what they're supposed to do. But it would be nice to have vaccines that actually prevent infection. And that would be an enormously important step forward. And the idea of using vaccines right directly into the area where you get your infection in the nose seems to be a very interesting platform. It's being worked on very quickly right now, but it may take a couple of years before the first one is rolled out for COVID. There is a nasal vaccine for influenza available currently, but this is a very interesting modality to look at. So with the modified Omicron-specific Moderna and Pfizer vaccines, these vaccines appear to be very safe. There's been some concern, well, they didn't have the same trials that the original vaccines had. Millions, frankly, billions of doses of mRNA vaccines have now been used around the world. These are the most studied vaccines we've ever had. Yes, it was in a relatively short period of time, but that's the perk of having deploying these things in the middle of a pandemic, is that you just get lots of people who take the vaccine. And they've really proven to be very, very, very safe and very effective at protecting people from serious illness and death. The question is sort of, well, why do I want to get another booster when I've already had a few boosters? And there's a very interesting idea with a sort of a weird name called the concept of original antigenic sin. This was devised in 1958 in reference to influenza, and the fellow that came up with this term was the son of a pastor, so he maybe had a very keen knowledge of original sin. But the idea is that your immune system responds to the very first time you either have infection or a vaccine, and it's that very first experience that's really imprinted on the immune system. It's that piece that lays down the sort of fabric of your immunity. And that each time you have a subsequent booster, and we do use boosters a lot for different kinds of vaccines, hepatitis B and rabies and tetanus and influenza, of course, is a great example, that the boosters may add a little bit of variety and may increase neutralizing antibodies, which are kind of the first players in an immune response, but they're probably not going to really change that original imprinted response to the pathogen that it experienced the first time you got the vaccine. And this has been shown that in animal studies that when you do boosting, either with the original vaccine or with the Omicron-specific vaccine, that they perform equally. This has not been seen in humans because we're just now deploying this vaccine. But I think there's still an argument to be made that an Omicron-specific vaccine is of value. It is a little bit different, so it may add a little bit more diversity to your immune system. And it is very clear that boosting has a significant benefit. And there's a possibility that if we have more specific vaccine directed at the circulating virus at the time, that may diminish the actual infectiousness of people so that they're not transmitting the virus to one another. So I think it's a worthy endeavor. It's a safe vaccine. And I think that it's probably going to be a very useful modality as we move forward. I'm going to be getting it because I'm about 6 months out of my booster. I think it's going to be released by CDC for all individuals over 12 for Pfizer and over 18 for Moderna. You may have heard that Moderna is suing Pfizer. That's a whole other story, but it's very disappointing. But they both perform equally well. And again, this business about mixing Moderna and Pfizer doesn't really matter. You can do that if you like. I sort of am a Pfizer girl, so I sort of stick with Pfizer. But I think it's a good thing to go ahead and think about if you're more than 4 months from your last booster and you have not had COVID. If you've recently had COVID within the last 2 or 3 months, you might want to wait for this vaccine, this booster until maybe November. The idea is to try to get everybody's neutralizing antibodies ramped up a little bit in preparation for the fall and winter. when we know we often have a very serious surge. It happened last year. Of course, it was a nightmare the year before. So we're trying to kind of come up with some tools to really tamp down that issue. And I noticed that Adam is picking his nose over there. This is kind of weird on that old Renaissance painting. So finally, the new emerging things that are of concern, BA 2.75, which is a new variant that's been circulating in India. That's not the variant. This is actually a picture from the Webb telescope. I just thought it was pretty cool. And Mike Eastwood is on this call, so I thought he should see this. But BA 2.75 is a disturbing variant because it does seem to be even more evasive than the BA5 variant, but it hasn't really taken off. It doesn't seem to have the robustness that BA5 has. So some people are referring to it as a scariant, but maybe not a new variant. We'll see. We certainly need to be vigilant about the emergence of other variants. And so there's a real need to be just doing excellent genomic evaluations in wastewater and throughout the communities to make sure we don't miss the next problem. Okay, now I want to talk about another virus that has taken hold here in the last few months. The nomenclature of monkeypox is very misleading, if not a bit, just not a good name. First of all, monkeys can get infected, and in fact, the reason why it's called monkeypox, it pertains to an outbreak of monkeys in a biologic laboratory in Copenhagen in the 1950s. That was the first big outbreak of this pathogen. So the World Health Organization is fast trying to come up with a new term for monkeypox. Mpox seems to be the favorite one, but MPX or human MPX V, human monkeypox virus V. But I unfortunately think monkeypox name is going to stick for a while. But it is becoming a little bit of concern here, and it's a small not small. It's an outbreak that has taken off fairly quickly. This virus is a member of the Poxviridae family, the same family as smallpox in the orthopox virus genre, and cowpox. And it's long been endemic in Central and West Africa. And as always is the case that endemic pathogens in underserved countries never get any attention until they spread into developed countries. And that is something that we absolutely have to address as we move forward, trying to prevent pandemics, because it is very clear that we live in a very small planet where things can happen all over the world very quickly, and zoonotic and other kinds of infections can emerge from very remote places and spread very quickly. So if ever there's an example of the need for global equity, this pandemic has really taught us that. The COVID has taught us that. Monkeypox is certainly another example, though. The first human case was in 1970 in the Democratic Republic of Congo. It is a zoonotic infection. In other words, it is transmitted from animals to humans. The main animal reservoir are not monkeys, as I mentioned. It's these Gambian giant rats and perhaps other rodents, which may be a little bit of concern as this virus spreads in urban areas. You might remember that these things are about the size of a beagle. They're actually used to sniff out the mines in places throughout Africa where there's a lot of leftover landmines. And so they're actually very intelligent animals, but they are a reservoir for monkeypox. As I mentioned, this disease probably originated in Africa, and the current clade or type of monkeypox that's spreading is from West Africa, not Central Congo Basin. That seems to be a little bit more virulent. There's been more deaths and so forth reported with that particular sub-variety of this virus, but it's spread pretty quickly around the world. And again, that just speaks to the rapidity with which people can travel from a very remote part of the world to a very urbanized, populated part of the world and bring a disease with them, and then it takes off. These are the number of countries that are now reporting cases of monkeypox, and these are the number of cases around the globe right now. So as of the 22nd, there are about 47,652 cases of Mpox around the world, 17,432 in the United States. Happily, no deaths. So there has been a death in Texas that they're looking into if it may have been related to Mpox. So it is of concern. It can kill people if it disseminates and has secondary problems. We've got about 1,400, maybe 1,500 cases in LA County. Pasadena's had about 17 to 20 cases. We've seen it with some regularity now in our emergency department. So it is out there, and it is something that we need to really pay a lot of attention to. I want to just make a comment about the populations that are high risk right now. That's unfortunately, once again, these diseases the first population that they affect may end up being very marginalized. And that really is such a terrible thing. We don't want to repeat what happened at the beginning of the HIV pandemic. This is just a virus. It doesn't care what your sexual orientation is or who you are or what color you are. It just wants to find a non-immune host. It is started in the MSM population right now, and that's something we need to pay attention to, because we need to reach out to those communities to get them vaccinated and treated. But I think it's fully likely that this is going to spread into the general population because it's highly infectious, and we know that happens. So we need to be transparent and candid about where the virus is starting, but not stigmatizing and accusatory, because the virus doesn't care. It just wants to find a person that's not immune, and it'll start in that population. The symptoms are not unlike COVID at the beginning. You can have fever, pretty severe fatigue and malaise, and severe achy bones. The difference is that patients with Mpox often will have lymph nodes that are very tender. They can be submandibular or cervical or inguinal. Headache is a pretty common feature. And then, of course, the rash is what's typical. This is papular pustular rash that's in the same stages of development. That's a very important distinction. Varicella, the virus that causes chickenpox, and zoster, the virus that causes shingles related to chickenpox, those pustules are in different stages of development. You'll have some early ones, and then some later ones, and then fully crusted over ones. With variola, with smallpox, and with monkeypox, and with cowpox, the pustules are all in the same stage of development. They're very painful. And they last for about 2 to 4 weeks. And while the pustules are present, that individual is infectious. So it actually has a fairly long isolation period, which really is very difficult for people to do. It was bad enough with COVID when it was 10 to 14 days. This one's about 4 weeks. And that has significant mental health issues as people try to isolate and not spread the disease. This is what the pustules look like, all pretty much in the same stages of development. They can occur in the palms of the hand. That's not real common for lots of rashes. Of course, secondary syphilis, I'll show you a picture of that, does do that as well. But this disease tends to like to go to the palms of the hand and the fingers and the genital areas and in the mouth. This is secondary syphilis, another rash, but looks very different. They're not pustules. It's these flat lesions. They're not painful, but it is important to be able to differentiate that if you're a clinician in the emergency department between the two. Transmission with Mpox is usually prolonged direct contact. This probably isn't a disease you can pick up on a toilet seat, but it can be from contaminated items or clothing and linens. It really has to be direct contact with body fluids and secretions. If an individual has lesions in their mouth, it could potentially be an aerosolized transmission or a more intimate infection. And you actually can get this also by being scratched or bitten by infected animals. And animals do get infected with this same variety of virus. There's been an Italian greyhound in Paris that got Mpox from his owner. And that is something we're concerned about. As you pet dogs or cuddle with dogs and you have lesions on your skin that are weeping out infectious material, the dog's skin can be a place where other people can pick it up, or the animal themselves can get infected. And so, so domestic pets are a concern, and we're quite concerned about the possibility of this virus getting into the urban rodent population. And then that would establish a permanent sort of source, if you will, for this virus, and might eventually become an endemic pathogen. We make the diagnosis by scraping the lesion. This is a DNA virus, unlike COVID, which is an RNA virus. DNA viruses don't seem to mutate as quickly. They don't replicate as quickly as RNA viruses. So they're generally kind of the same old virus all the time, which is good news from a vaccine and therapeutic standpoint. So the lesions really are very helpful in making the diagnosis. You have to scrape the area, and that's sent off to the labs, and they usually takes about 2 to 3 days for a turnaround time. There is a short period of virus in the blood, or you can get a blood sample, but it's so short that that's really not a very accurate way of diagnosing. It might be negative, even though they're well on their way to developing Mpox. And there are commercial labs that are turning this around pretty quickly. There are some platforms that some hospitals have. Cedars has one, an orthopox platform where they have a turnaround time of about 2 hours. But that does have to happen as we have to improve in the speed with which we make the diagnosis. You may have heard about Mpox or tecovirimat, which is an antiviral. This medication has been part of the national stockpile. It was studied and developed for the use of smallpox in the event of a bioterrorism attack. And what's sort of ironic is that the animals that were used to study the development of this drug, they gave them Mpox. So the monkeypox was used as the prototype for developing this medication in the event of a bioterrorist attack with smallpox. Smallpox, of course, supposedly has been eradicated. So this treatment is quite effective. It seems to really relieve some of the symptoms, and it is fairly well tolerated. Unfortunately, it's in short supply. And this is once again sort of deja vu that we've had with COVID, is that not being prepared, anticipating different types of viral illnesses, and not having a wide array of different kinds of viral medications that we can use to treat an emerging infection. SIGA is the company that makes this, and they're fast trying to make some more. And the Biden administration has been releasing tecovirimat from the national stockpile. For that reason, we don't just give it to everybody. We try to reserve it for individuals who have underlying immunocompromised conditions or are severely ill. It does inhibit the replication of the virus. It's most of the time given orally, but it can be given intravenously. It's a 14-day course. The medication is free, but as I said, it's in short supply. So we have different designated urgent cares around LA County that are providing testing and treatment. And that's probably the best places that we can refer them to. We do carry it at the hospital for patients that require inpatient management, but it's in short supply and hard to get. So it's something we want to kind of be very equitable about treatment. This is for clinicians in terms of deciding who gets treatment and who doesn't. Obviously, if somebody's very, very sick with Mpox, then they will need to be admitted to the hospital. If they have confluent lesions, they've got sensitive anatomical sites inside the genitals, or or they have encephalitis. If they're severely immunocompromised, and that includes poorly controlled HIV disease. Many of the patients I've encountered so far are HIV positive, but they have well-controlled HIV disease. If their HIV is not well controlled, then that's an individual you might think about giving tecovirimat, because they could go on to more dissemination. Cancer patients, that have had organ transplants, or who are taking other immune suppressing medications. A bit concerned about young people. Kids don't do terrifically well with this disease. There have been 4 pediatric cases. There might be more now. I haven't looked at that data yet or recently, but it is something to keep in mind. It does appear to be safe for using in children. It isn't clear whether this medication is safe in pregnant women, but at this point, the CDC says if you have an immunocompromised, severely ill, pregnant, or breastfeeding woman, they probably should get this medication. So there are very specific indications for using Mpox. This is a picture of the pill. And again, as I said, it's usually the standard as an oral therapy that you take twice a day for 14 days. So in an effort to try to prevent this disease in high-risk populations, the National Stockpile has also released the Jynneos vaccine that was designed to treat and prevent smallpox and monkeypox. This is a live attenuated vaccine. It's reasonably safe to give in people with immunocompromised conditions. We don't generally like to give live attenuated vaccines to folks with severely immunocompromised immune systems, but it can be given to people with well-controlled HIV disease. And it is a 2-part vaccine. It's about 4 weeks apart. There's been a real shortage of this. And in fact, LA County got only about 60% of the dose that was promised to them from the national stockpile. This is also being rapidly ramped up in terms of its manufacturing. But one modality that the CDC and the FDA have come up with is that by using a different way of administering the drug. Normally, this drug is given subcutaneously. And if you give it subdermally, right under the skin, that's actually a way you can do 1/5 of the dose to elicit the same response. And if you think about it, for those of us that are old enough to receive the smallpox vaccine, we got a little fork prong thing. Women tend to get it on their inside of their arm. Some people got it on the outside, that caused a little crusty lesion. The skin is a very immunogenic part of your immune system. And so giving vaccines that way is often a good way to sort of extend the number of doses that you can get. And so that's what's being recommended right now. doesn't require a high skill set. Most nurses know how to do this, and that's what we're recommending at the clinics for Jynneos, the monkeypox vaccine. In terms of preventing infection, N95 masks, if are still used, we use those with our patients in the emergency room. Because this is a contact transmitted virus, it's important to wear protective gear when you're evaluating a patient, including eye protection, and of course dispose of the gowns and gloves and linens properly. Just another reason to wash your hands, and of course always to stay informed and rise to the occasion once again. Again, it is taking off a little bit. It doesn't seem to be spreading quite as quickly as we would fear if it was really out into the general population, but it's imperative that we get on top of it, that we identify people with the disease, get them some therapy, get them vaccinated, and try to extinguish this as fast as possible, because it really could be a more significant problem. So we're not quite there yet, but we're watching it very carefully. And just when you think it was safe to go back in the water, it's never safe to go in the water. And by the way, don't go to the beach right now. There's a lot of concern about some high bacterial counts in some of the local beaches, even though it's so hot. But poliovirus has been detected in New York City. Wastewater analysis has turned out to be a very useful technique that sort of found its niche during COVID. And so we do it in LA County, it's done in San Francisco and in New York, where they look at molecular footprints that are in the wastewater coming through sanitation plants. And it's a way of kind of predicting what might be coming down the pike, or assessing whether there's going to be a surge. And so you'll start seeing that in the wastewater. It's a little, you can't discern whether it's coming from animals or humans, especially viruses that can be in both. But it is a very important technique now that's being widely used. It's relatively inexpensive. It's kind of yucky, but it works, and it's an important detection tool for emerging pathogens. Poliovirus, of course, we thought we had really seen the last of this. And I think this speaks to the problem that we have now of a large portion of the globe that are not vaccinated or have no immunity against pox viruses. Part of that is because we happily have really eradicated poliovirus. Part of that is because there are many individuals who are not vaccinated, and there's still many individuals in our own country who don't get vaccinated for common diseases like polio. And so that's one theory of why monkeypox or Mpox has taken off so much, is that there just wasn't that sort of layer of immunity that perhaps we had 15 or 20, 30 years ago when people had been vaccinated for smallpox. So there's been a few cases of poliovirus in individuals who were not vaccinated. And Europe and much of the Middle East are still using a live polio vaccine. And so that can potentially infect someone who doesn't have any immunity to polio. So the United States uses a killed polio vaccine, but it is of concern because we're detecting this, and so it's something to watch. And I think it's important to understand both the economic and human toll of what happens when we have these pandemics. COVID has been a wake-up call, really, for how dangerous it can be when something gets away from you, and it's so infectious and can affect every single person on the planet. And I think that it's not surprising that we are seeing this really dramatic change in life expectancy over the last 2 years in the most developed country in the world. And that's really kind of a sad story. And of course, there are always populations that are unequally impacted by this. And we certainly see that in our marginalized populations in the United States and people of color and our Native American populations. But the life expectancy in the United States, especially in males, has dropped by 4 years, which is really significant. And that's largely due to COVID and the aftermath of COVID. But that really speaks to the human cost of pandemics and infectious diseases that get out of control. And of course, then that also translates into the economic cost of that. Over 1 million Americans have died of COVID. There's been almost 7 million deaths around the world. That's probably an enormous underestimate about the number of people who've died from this disease. It is a truly enormous pandemic that has really wreaked havoc around the world and continues to do so. And it should be a very hard lesson for us to learn that we need to stay on top of viral pathogens and monitor their emergence and be ready for the next pandemic, because there will be one. This is also my opportunity to remind everybody to get their flu vaccination. Australia has had a significant uptick in their influenza. And remember, the Southern Hemisphere gets their flu season before we do. You know, for the last 2 years, people have been mostly masked. And so we haven't had particularly big flu seasons. And it's kind of important to actually have some flu circulating because that helps build up some immunity in the community that's suffering from it. We do have a new vaccine out. It's available right now. I strongly encourage everybody to get that as soon as possible because this could be a more virulent flu season. The H3N2 varieties of influenza tend to be nastier. And then just to kind of give everybody the heebie-jeebies is that when there's a porcine, a pork influenza virus that's been reported now in about 8 individuals in the United States. And whenever there's those kind of things, that's how H1N1 came back to haunt us in 2009, when there's these animal transmitted viruses, even influenza that we've seen. So it just really speaks to the fact that we have to be vigilant. We have to do the things we can do to prevent infections and be very humble that infectious pathogens are looking for ways to infect us, and we have to try to stay ahead of the game. And I think that this is a time just to really be very reflective on what happened, why this is happening. The pandemic is not over. I've heard people say back when we had COVID, well, we still have plenty of COVID and it's still with us. Are we better prepared? Yes, but we could have been so much better prepared had we really paid attention to what a lot of scientists and clinicians around the world thought was going to be a pandemic coming at some point. So what can we do? If we can have the Webb telescope taking fantastic pictures of other universes, maybe someday we'll be able to move to a different planet when our own planet becomes uninhabitable. But right now that isn't in our capabilities, and it also isn't a very good idea. We need to try to protect what we've got here. And so there's many ways of doing that. The most important from an infectious disease standpoint is to really be vigilant about emerging infections and trying to keep a very tight surveillance on what's happening around the world, in developed countries, in developing countries, in resource-rich countries, in resource-poor countries. We have to have monitoring with easy, robust, not terribly technical equipment to look for viral or bacterial pathogens or even parasitic pathogens. We have to have a network of data that is easily transportable to areas that are resource poor. And it is the responsibility of the resource-rich countries like the United States to help reach out to the resource poor countries like Tanzania, where we work, to make sure that they have the same access to the same information and the same capabilities of identifying new pathogens and protecting their populations. And that makes societal sense, it makes economic sense, it of course makes humanitarian sense, and it helps protect the world and keeps things in a much better place where we can identify things earlier and get on top of them. And so there's many parts of this. We have to have the global pathogen surveillance organizations and really empower countries and provide funding for those countries that can't have some of the more sophisticated equipment. But we need to develop novel ways of looking for viruses, for testing for infected individuals, and really staying on top of what's happening in animal transmitted viruses and other things around the world. We have to have environmental stewardship. Climate, of course, is impacting all of us right in front of us. This whole week is going to be a nice example of what happens when climate change is right on top of us. But this really impacts the emergence of infectious diseases. A warming planet is much better for vectors such as mosquitoes and fleas and other insects that can transmit disease. It changes the patterns of migration of animals so they encounter humans more frequently and can transmit diseases. We have to protect wild areas and protect and have good animal wildlife stewardship. And it's important that we work with veterinarians and zoologists and biologists who are out there in the field identifying diseases in non-human species, because those could easily become pathogens for us. We have to have global economic equity. It is important that not just WHO, but other organizations invest and support developing nations. Nonprofits such as ours, small organizations such as ours, large organizations, the CDC, all of these have to be given robust support so that we can really help countries around the world develop their own protected public health departments. And it's very important that we put money into our own public health system. I think a lot of people didn't know what public health officers did until COVID came along, but they are an enormously important part of pandemic identification, response, implementation, and protecting the population. And they have done a yeoman's job here. This has been an enormously difficult time for them. Many of them have had threats against their lives and their jobs. But we owe an enormous amount of debt to the public health people, the local individuals, all the way up to the CDC in terms of trying to get this thing under control. Political stability comes with investing in economic equity, and we have to gear that towards gender equality for marginalized populations and especially for children. That type of political and human rights are essential for a safer, less infectious planet, so that you can deploy healthcare techniques and staff out to areas that are having issues with drought and famine. There's a terrible famine going on in Sudan right now. And these areas, when large populations of people move because of political instability, that brings diseases with them. That's when you see things like cholera and malaria and lots of parasitic infections that kill children particularly. We have to have medical equity around the world. Novel medications are not just for rich countries. They should be for poor countries as well. We've seen the vaccine rollout be a little bit uneven, but it is happening. And to the credit of some of the vaccine manufacturers, they tried to not have it be something reserved specifically for developed countries. But it's critically important to getting diseases under control. If we can do all these things, and that's a great lift, then we'll be in a better place. And we have to learn from this experience. Much of what we're doing with COVID is on the shoulders of what we did for HIV, both the clinical, scientific, virologic, and medical aspect of it, but also the societal and political and economic aspects of it. And I think that the legacy of the many, many individuals who've died from HIV is that that's helped us get through this pandemic with medications, with how do you do testing, with how you deploy this sort of thing in high-risk populations. So as we conclude here, I always like to go back to Guy de Chauliac, who was a famous physician during the plague. And he didn't flee the city. He carried on and took care of his patients, never got the plague himself. And I think that's what all of us have to do as citizens, that we have to step up, help our neighbors and our families and our society, and be open-minded and support the organizations that are around the world, in our country and around the world, that are protecting us from infectious pathogens. Dr. Goodall, and she always has a great saying: you can't get through a single day without having an impact on the world. So everybody can have an impact and do something, and that's what we need to do. These are just some references if you're interested, and I'm happy to take some questions. If you're still there.
There's some questions in the chat.
Oh, there's questions in the chat? Okay. Okay. Let's see. I've had 2 boosters. When should I get the Omicron specific booster? If your last booster was more than 4 months ago, get the Omicron specific booster. If you haven't had 4 boosters, if you've only had 2, or if you've had 2 on top of your prime, then if it's been 4 months, 3 to 4 months between your last booster and now, get the Omicron specific booster. Is it true that blood type O people are totally immune to COVID? And are there blood types that are more vulnerable to COVID? That never really has panned out. There was a lot of sort of noise about that, but I took care of several patients with type O that had COVID. It's sort of, there may be some individuals that don't get COVID for other reasons. Perhaps there's something about their receptors on their ACE2 receptors. We know that certainly happens with HIV. We just don't know yet. But a blood type is probably not, it's kind of a gross, not gross, icky, gross sort of overarching look at the immune system. And it's probably much more subtle than that. What kinds of severe skin diseases increases one's risk for Mpox? Things like atopic dermatitis, psoriasis, bad psoriasis, probably severe eczema, especially skin diseases requiring the use of immunologic agents to treat them. Those individuals, I would worry about getting Mpox, and they should probably get tecovirimat. One new message. What happens when I do that? What do you tell people who say having COVID provides as much protection as being vaxxed and boosted? Well, there is some truth to having natural infection gives you some immunity. The problem is that wanes. The best combo is to be vaccinated and then don't go out and get COVID. But those individuals have very high levels of neutralizing antibodies. So we know that natural disease does give you some protection, but it begins to peter out. And it's a lot of those individuals that did not get vaccinated who got natural disease, who then went on to get it again and aren't doing very well. And so there's probably some we know there's extra immunity when you're vaccinated. Even if you've had the disease, get vaccinated because it really does increase your risk for not getting severely ill and certainly not having a bad outcome. Do we have a picture of the COVID situation in Africa and in particular in Tanzania? You know, the continent of Africa has been problematic because reporting has been so spotty. And there's been some countries, including Tanzania, where for a while, the countries were not reporting COVID because they wanted to sort of ignore it and say it wasn't happening. There's also sort of this idea that maybe there's been less COVID on the continent of Africa. I think the data is still not clear on that one. That probably is a little bit more of underreporting rather than anything about the African countries having less of a problem with COVID. It's possible. They generally have a younger population. They also have, poor countries, often people are outdoors more. We know that outdoors really is a much less effective environment to spread the disease. And I think that, so it's pretty much what it is here. Vaccines are available in Tanzania. Most of the J&J vaccines have been used in developing countries because they don't require the ultra cold preservation that the mRNA vaccines require. That's where Novavax may come in and be a very useful vaccine because it also can be in room temperature. And then somebody above that asked, when do you imagine the new booster will be released for everybody? It's going to be released probably for anybody over 12. This last booster was sort of kept to people over 50. But now I think tomorrow the CDC is going to review the FDA's recommendations. I suspect they'll approve it. And so anybody over 12 should probably get a booster. So for young people, I think this would be a good thing to get them through the winter. If you were, if you were immunized against smallpox as a child, do you have any protection against Mpox? If you were immunized against smallpox, does one require only one Mpox vaccine? And then how long are you contagious with Mpox? If all the lesions are scabbed over, say within 2 weeks, are you no longer contagious? And finally, is it like chickenpox, wherein you're most contagious before developing lesions? So we don't know whether having had smallpox vaccination will protect you at all from Mpox. There is a lot of overlap because they're very similar viruses, so it could. The patients that I have had contact with, I usually am the person who calls them with their positive tests, have all been relatively young, too young to have received the smallpox vaccine. So it's a possibility, but unlikely. Excuse me for some. Got a cat really. It's an Eastwood cat that's getting into trouble here. Sorry. You're contagious with the Mpox virus as long as you have any lesions. They have to be completely healed up. So scabbed over, you're still potentially contagious. That's why it's probably a 4-week isolation, which is really unfortunate. And are you most contagious before you develop the lesions? I don't think anybody really knows that just yet, but it's most likely spread because it's a contact spreading virus, most likely spread from the lesions. Okay, let me see if I can file down here. Can more and more boosters decrease the body's immune response wherein the body in effect says to COVID, you again, meh. Well, if the body says that, that's a good thing. There's this original sin idea sort of speaks to that you may, the sort of diminishing returns with the numbers of boosters, whether it decreases your body's response, probably not. Because again, your body's going to look back at the original vaccine or disease that you had and mount the response to that. It is something to think about as we move forward, but doesn't seem to be the case at this point. And, we know for influenza, for example, influenza vaccines are highly protective. There's a fair bit of influenza that's conserved from one year to the next. It's when there's a completely different virus that comes along that we have a big outbreak. So your immunity that prevents infection is very short-lived. Your immunity that prevents severe disease is longer-lived. And that's maybe where boosters are not as helpful. I think that's all the ones in the chat. Does anybody have a regular question? A person question?
There's a new one in the chat.
Oh, there's a new one in the chat. If you wait long enough. If my family members had COVID, including a 19-month-old and 2 adults under 50, should they all wait until November for any new boosters? Well, the vaccine has not been approved for children less than Pfizer's been approved for children over 12, Moderna for over 18. So the 19-month-old isn't eligible anyway. And the adults who've had it should wait 3 months before they get their booster if they just had COVID. Any other questions? Well, thank you, everybody.
Thank you.
It's been a pleasure, and we will be looking forward to some new speakers coming up in October. I highly recommend, if you're interested in sending the, send the invitations on to friends that you think might be interested in hearing two really good speakers. I think I'm very excited about Jane Olson and Colin Carlson, and then of course we've got, I'm sure Larry will be entertaining, and Jane's always good. So got some good folks.
Well, thank you so much. This was wonderful. Thank you.